All right. Hello, everyone, and I hope there are many of you joining us. We're about to start on a new adventure. We're part of the clinical task force from NAC, and we are having this great opportunity to present you with a session today that we've put together to discuss some of the most important social determinant issues around research. So I'm going to tell you that we have a very packed agenda, and so what I'm going to try to do is ask all of our participants to stay quite within their time so that we'll have a chance to discuss some of their presentations. We're going to begin with two really important keynotes, people who have been working in this area and have really wonderful technologies and information to tell us about. And then we're going to do a quick data blitz and go through several presentations for some of our newer members who will be giving us some details about what they've been working on. So without further ado, I'm going to introduce you to Lisa Barnes, who's going to talk about social determinants and cognitive aging. So Lisa, let me ask you to take it away.
Great, thank you. Share my screen. Wait a minute. Okay, good afternoon, everyone. Thank you to the Clinical Core Steering Committee and the Task Force for organizing this really important session. My goal today is to give you a broad overview of social determinants and how they've been used in cognitive aging research. So it's well accepted and well recognized that health is not solely determined by biology, but also by social determinants, which are the social conditions in which people are born, live, work, and age. On this slide, I'm showing you some of the major categories of social determinants in the ovals, and then the boxes show you how people have conceptualized these major categories. There's a long history in public health research linking social determinants to health across a wide variety of diseases, including the progression and onset of disease. Some of these have been looked at with cognitive aging, but we can do a lot more work in this space, particularly with ADRD biomarkers. And why are social determinants important? Well, here I'm giving you some examples of why it's important. We know that there is evidence of persistent racial and ethnic disparities in brain health among older adults. Whether you look at incidence of dementia, which I'm showing the slide by Maeda et al., using data out of Kaiser for dementia incidence, or you look at cognitive aging from our group in the Chicago Health and Aging Project on the bottom left, or you look at differences in pathology at death in those who are demented. These are data from the Rush Clinical Core. No matter what the outcome, you see that African Americans have poor brain health outcomes than their white counterparts. And if we just stop here, we would incorrectly assume that these differences are due to something about race. But we know that race is a social construct. It's not rooted in biology. So looking at social determinants will allow us to sort of unpackage the ways that these social and environmental factors may be the root drivers and root causes of these disparities. Now, work for social factors and cognition is not new. It's been going on for about 2 decades with early work by Berkman and colleagues and Winblatt and colleagues who showed that social factors are related to both incidence of dementia as well as cognitive decline. We also looked at social resources back in 2004 in the Chicago Health and Aging Project and found that people who reported more social networks and greater social engagement had slower rates of decline in African Americans and whites in the Chicago Health and Aging Project. And in a second study out of the Rush Memory and Aging Project, we showed that social networks actually modified the association of AD pathology to cognition. So, but even though all of this work had been going on since the early 2000s, it wasn't until very recently that there's been this increased interest in looking at social determinants with cognitive aging. And in the next few slides, I'll show you some examples of how people have sort of done this in this space. So one way that you can look at social determinants is to look at between race differences, and you can also look at the life course. And this is a really nice example from YCAP by Cisco et al., where they looked at early life educational quality, which was conceptualized by the different indicators you see in the boxes to the left, as well as late life literacy. And they found that these two things together accounted for racial disparities in cognition and level of cognition, but not change. It reduced the racial difference by about 1/3. Another way that you can use social determinants, though, is to look at within group differences. And this is a nice study by Maeda et al. That's under review, where they looked at another life course factor, work-family demand patterns in women in the HRS. And so what you can see is that there weren't much differences before age 60, but after age 65 is where you start to see the split, where women who participated in the workforce in early life and midlife have a slower rate of decline in memory than those women who did not engage in the workforce, as shown by the two dotted lines. Now, stress is another great indicator of a social determinant, and you'll hear more about this in Megan's talk. But we looked at perceived stress in the minority aging research study with the 4-item perceived stress scale that accounts or tries to capture the extent to which a person finds their life unpredictable, uncontrollable. And we found that those people who scored at the highest, the 90th percentile of perceived stress, shown in the blue lines, had a faster rate of decline in episodic memory and visual spatial ability than those who scored at the 10th percentile. Another social determinant that I think is really powerful and that is certainly relevant in today's climate of civil unrest is the Everyday Discrimination Scale. This is a 9-item scale that was developed by David Williams and James Jackson in 1997 to measure common microaggressions. It has been used in hundreds, if not thousands of studies. It's very easy to administer, and it's very predictive of all kinds of mental and health outcomes and physical health outcomes. The nice thing about the scale is that it can be used across racial and ethnic groups because there's no framing about race and ethnicity in the questions. So you can even use it in whites. It also can be used to assess all kinds of discrimination because there's no questions that ask about the attribution or the source of discrimination. And so this scale had primarily been used in college-age students and midlife adults, and we were one of the first groups to look at it in older adults in about 2004. But in 2012, we looked at it with cognition, and we found that those who reported in the minority aging research study, those African Americans who reported higher frequency of discrimination had poorer performance on global cognition, episodic memory, and perceptual speed. And models adjusted for demographics. Now, this work has since been replicated and extended by Zahatni and colleagues, where they looked at this scale in the HRS across race and ethnicity and found that it does predict not only lower levels of cognition, but also faster rates of cognitive decline in African Americans, but not whites. And my final example is a study that we just recently published in the Minority Aging Research Study, where we looked at place of birth in the US and its association with level and change in cognition. And we found that those participants who were born in the South had lower performance on our cognitive function test, but there was no effect on change. Now, we also asked about their experience attending a legally segregated school, because as we know, this is an age cohort who would have attended school before or during the Brown versus Board of Education mandate, which outlawed segregation in schools. And while we didn't find a main effect of segregation on cognition, we did find this interesting interaction with place of birth, such that those who were born in the South and attended a legally desegregated school, so they went to school with other whites, had the lowest performance of any of the other groups. Now, this is not a finding that's surprising for scholars who study race and racism, but I think it shows the importance of understanding the social context and how that may affect cognitive test performance in diverse populations. A few years ago, the NIA came out with the Health Disparities Framework that provides a representation of the many factors that should be considered, not only to understand disparities, but to help us understand causal pathways linking these factors to health and disease, some of which I've shown you in the prior examples. I'm not going to go through this slide in detail, but if you haven't yet read this framework, I encourage you to look at this, because I think it can help us really think about and design more robust studies to understand some of these differences we're seeing across race and ethnicity. So in conclusion, social determinants can be measured in everyone. They can and should be measured in everyone. They are not just measured in diverse populations or poor people. There is a spectrum of social determinants, and everyone can get a score on these scales. I think that they can be used to understand heterogeneity in cognitive aging, whether you're interested in understanding racial, ethnic, gender, or SES differences, or whether you're interested in understanding individual differences within groups. And finally, as we are having this increased interest and emphasis on inclusion of diverse populations in ADRD research, I think we can use social determinants to design robust studies to determine whether or how social determinants are associated with our outcomes of interest, in particular with biomarkers of ADRD. I didn't show you any data of race and biomarkers, but there have been a couple studies already that have shown racial differences in biomarkers, and they have been discrepant. So it's possible that incorporating social determinants in these studies could help us sort of resolve some of these discrepancies. So I thank you for your attention, and I look forward to the discussion at the end of all of our presentations. I'll stop sharing my screen.
Off of mute now. Can you hear me?
Yes.
Yeah. This is okay. Great. Well, so this was really great, and we're going to go on to our next speaker. We'll save our questions till the end. I'm next going to introduce Amy Kind, who's going to speak to us about the power of context and considering multi-level social determinants in brain health. So Amy, let me ask you to begin.
Thank you, Dr. Sano, and thank you, Dr. Barnes, for setting up this talk so incredibly well. She gave a wonderful overview of the individual level social determinants of health, and we're going to transition to talking a little bit about context. So thank you for the invitation for being here today. Just to start out with some disclosures, you can see my current and recent past funding there. I do some consulting for Legatum out of the UK, that is unpaid, and with the UW-ISMIS project. So as Dr. Barnes had mentioned, social determinants of health are critical in the health and well-being of human populations, and this has been recognized for decades. This happens to be the CDC's health impact pyramid, and you can see here by far the largest impact in human health in general is felt to be derived from socioeconomic factors and the social determinants of health. Dr. Barnes highlighted the NIA Health Disparities Research Framework, and I'd like to highlight it again because it is a wonderful tool that helps us understand that the mechanisms which underlie health disparities tend to be multifactorial and multi-level. And we're going to be focusing on not only the individual level social determinants, but also on the context that individuals live in and how that context can influence health. So living in a disadvantaged US neighborhood is extremely strongly linked to mortality and disease. This has been known for decades. cardiovascular disease, diabetes, obesity, cancer. And these associations exist even after accounting for individual level SES factors. Neighborhood disadvantage influences many factors about health and health behavior, whether one can access healthy food, whether one has lead in the water, whether you're subjected to safety issues. And overall neighborhood disadvantage is critical. Dementia clinical syndromes do disproportionately impact populations that are exposed to neighborhood disadvantage. And we can also say that quantifications of neighborhood disadvantage can be employed to learn about the health of populations across a number of different spectrums. This becomes important because these geospatial metrics of neighborhood disadvantage are the cornerstone of health policy in a number of non-US health systems. The metrics are robust. They tend to take many different constructs around the field of social determinants of health and summarize them into single indices. They become highly generalizable across the full US, and that they are statistically robust in that they can be incorporated into predictive analytics. They can facilitate mechanistic science, looking at the interactions between individual level SES factors as well as contextual level, and they've been used for resource allocation outside of the US. They're quite translatable in that we can design interventions specifically using these metrics targeted at community research and policy levels. And so for the last 15 years, our group has been working very hard in this domain, developing and refining something called the Area Deprivation Index, which is a summative index with factor-based scores that are drawn from 4 different elements from the social determinants of health: education, employment, housing quality, and poverty. And it takes 17 different constructs in these 4 theoretical domains and brings them into a single score. We refined this index down to the census block group level, which is about 1,500 persons on a population basis that's determined by the US Census, and it allows us to precisely measure the contextual exposure. This corresponds to similar type metrics that have been used in the UK at this geographic level for both policy, research, and practice purposes. So it allows us to follow a highly validated model across a large geographic area. We've been validating these across the US, and we've been sharing them through the Neighborhood Atlas platform, which I'll tell you more about in a moment. The power here is that we can harmonize these metrics across the full US. Every city, every state, every county can be ranked using these indices, with red being the most disadvantaged and blue being the least. It can also be used at a very precise level. As I mentioned, this happens to be Milwaukee County, one of the most poor counties within the state of Wisconsin. But you can see when you look at a very precise geographic level that the neighborhood, highly disadvantaged neighborhoods, are clustered within inner city Milwaukee, and you have this ring of extreme wealth right around the edge of the city, and particularly on the lakeshore. So we have a measurement and a precision of measurement that allows for decreased measurement error from the contextual level. But how do these neighborhood social determinants connect to brain health? Can we connect cells to communities and neurons to neighborhoods? Well, we're going to talk about that in a moment. Our group has been working on this quite hard over the last few years, and I'd like to highlight just 2 papers that have come out recently looking at biomarkers in tissue and how we can connect them to social determinants of health. The first paper looked at linking neighborhood disadvantage markers by the ADI to neuroimaging biomarkers. And we used 951 cognitively unimpaired participants from the Wisconsin Registry for Alzheimer's Prevention and the Wisconsin ADRC. The residential address was very precisely geocoded and linked to disadvantage, and MRI measures were used for hippocampal and total brain volume. This work was published in JAMA Neurology just earlier this year, January 6th, and it was with first author Jack Hunt, who's an MD PhD student that we work with, and it was in collaboration with Barb Bendlin, who's a wonderful partner and my MPI on this grant. She's a neuroimager that I'm sure many of you have worked with and know. To summarize this work, what we found is that living in the 20% most disadvantaged neighborhoods, these individuals showed lower total brain tissue volume and lower hippocampal volume. And even after adjustment for individual socioeconomics, including race, education, and SES, that is income, these changes persisted. And it was equivalent to about 7 years of age-associated hippocampal atrophy. Interestingly enough, cardiovascular risk mediated the association for total brain tissue volume, but not for hippocampal volume. Of course, these findings need to be replicated in larger studies and in other cohorts, but it does raise potential that residential location may be a risk marker for brain volume loss during aging. But we wanted to take this to the next step and really think about neuropathology. So I worked closely with Robert Rissman at the UCSD ADRC, and we looked at decedents who had donated their brains to one of 2 ADRC-affiliated brain banks at Wisconsin or at UCSD from the years 1993 to 2016. These were individuals who were not in nursing homes, so they died within their own home. And obviously we can talk about that a bit in the discussion section if people are interested. But these are individuals who had no social factor characterization. Many of these decedents died even before NAC existed. And so because of that, their tissue existed and was exquisitely characterized, but their social factors were not really further explored. So we used the residential address at the time of death to geocode and link to contemporaneous ADI. So we build historical ADIs that can go backwards in time and were affiliated to the same year of death. And the neuropathologic features were drawn in standard ways. This work just came out last week in JAMA Network Open. And it proves that we can do this. It's basically a marker of feasibility of some of these techniques and linking tissue to communities. So what did we find? Well, first, the distribution of samples was interesting. So within these 2 brain banks, there were many more individuals who originated from wealthy neighborhoods as compared to poor neighborhoods. So the red line here would be the level if all of these decedents represented the populations of the areas from which they were drawn. So it should be 10% across the board, but as you can see, there's quite a bit of a skew towards wealthy individuals who lived in wealthy neighborhoods. Also, we could say that increasing neighborhood disadvantage was associated with an 8.1% increase in the odds of AD neuropathology for every decile change in the ADI rank index, even after adjustment for the factors that were standardly adjusted. And living in the most disadvantaged neighborhood decile within this particular group was associated with a 2.18 increased odds of AD neuropathology. Again, this needs to be expanded into other samples. This is just an assessment of 2 brain banks, but it does prove the feasibility of this technique, and we are developing methodologies by which we can trace these decedents backwards in time in order to give us an understanding of their life course. But we also, a lot of our work involves data democratization. So we embrace this idea that we should have open science and that everyone should have access to the data that we produce. The data democratization can be a very challenging construct to achieve. It seems simple, but it's very hard. This idea that regardless of who someone is, they can use your data and act upon it. Our first activity in this has been the Neighborhood Atlas. I hope many of you have seen it. You do not need even a high school degree to use this tool. You can do real-time mapping, and anyone can download the data that I just talked about in terms of the ADI markers. They're freely available. Please use them, and I'm available if you have any technical questions. This is what the mapping looks like. You can see Maryland here. Baltimore, as compared to everywhere else, does show up quite strongly, but the use has been profound. So we published this work in the New England Journal back in 2018 and have had over 200,000 views and over 20,000 downloads. Everywhere from Congress to the CDC to IBM Watson has been reaching out to us around this. And the NIH has been wonderful about promoting this work as well. But in my last slide, I wanted to share with you some very exciting news that just came out of the state of Pennsylvania. So they are actively using these metrics to proactively mitigate COVID disparities. So policy right now that has been released from the Commonwealth of Pennsylvania in order to provide an ethical allocation framework for emerging treatments of COVID in those statistical models that decide who get the treatments and who don't, for individuals that live in highly disadvantaged neighborhoods, as based on our metrics, those individuals are much more likely to get remdesivir and some of the other COVID-specific treatments. So we're excited. I've been very busy working with people across the country with the coronavirus pandemic, and we're pleased that Pennsylvania has adopted this. It's been in operation for the last, I believe, 4 weeks. You can see the linkage here if you want to see more. And thank you. So ultimately, social determinants of health are important. These data are freely available to you. Please use them. The Neighborhood Atlas is available. Feel free to reach out to me if you have questions, and thank you for letting me present today.
Amy, that was great. We really appreciate how much you fit in this short time, and I know everybody has questions for you. We're going on to begin our data blitz, and so it's a real challenge, and we're hoping our speakers can do their best to stay on target. So let me begin by introducing our next speaker. Jaime Perales will be talking about ethnoracial disparities in mild cognitive impairment. Take it away.
Hello. So good afternoon. My name is Jaime Perales, and thank you very much for being here. I'm an assistant professor at the University of Kansas Alzheimer's Disease Center, and I'm going to present our recent publication on ethnoracial disparities in mild cognitive impairment. This work was partly funded by my NIH diversity supplement, and I would like to tell everyone and encourage every PI to apply for this mechanism to increase the diversity of their workforce. So let's start with the introduction. Cognitive impairment is impacting ethnic and racial minorities and will impact them even more in the future. By 2050, 40% of people 65 years old and over will identify as a racial or ethnic minority in the United States. This figure here shows how racism at many different levels can lead to cognitive impairment. Mediators range from the more distal ones, such as neighborhood deprivation, economic status, discrimination, to more proximal ones such as cardiovascular risk factors. There is a consensus that African Americans are twice as likely than non-Latino whites to have dementia, and in Latinos it's about 1.5 times more likely. Geographical differences in dementia risk among Latinos in California and New York, and also findings from the SOUL study, the study of Latinos, suggest that the risk of dementia and mild cognitive impairment might be different depending on the Latino origin. So for example, Caribbean will possibly have a higher risk than Mexican Latinos. Dementia risk in other groups has been much less studied, but a recent landmark study conducted by Mayeda, mentioned a couple of times already, in California suggests that Native Americans, but not Asian Americans, might have a higher risk of dementia. To our knowledge, no study has compared the risk of mild cognitive impairment among a wide number of ethnoracial groups in the United States, which is precisely what we aim to do. And particularly, we hypothesize that African Americans and Caribbean Latinos, but not Mexican Latinos, would have higher risk of MCI compared to non-Latino whites. We use data from the NAC-UDS. I'm sure everyone here knows what NAC is, but prospective data set of standard dementia evaluations conducted in the different ADCs across the United States. We included people 55 years old and over, cognitively normal at baseline, and with 2 or more visits. The main analyses included competing risk survival analysis, and the outcome was time to MCI. The independent variable, as you can imagine, is in a racial group, which I'll show later on. And we built models including several covariates that were either confounders, such as age, modifiable risk factors, such as cardiovascular health, and non-modifiable risk factors, such as ApoE4 carrier status. As for the results, here we show the association and subhazard ratios between the racial group and mild cognitive impairment risk, controlling for all confounding, modifiable, and non-modifiable risk factors. And as you can see, 4 groups still have a higher risk of MCI compared to non-Latino whites. And these groups are Native Americans, those reporting African American race plus another minority race, Latinos of two different origin, Caribbean and Central and South American origin. So to conclude, this study shows more evidence that ethnoracial disparities exist in mild cognitive impairment in different groups in the United States. Patterns are kind of similar to others shown in dementia. We found disparities in 4 groups, as I mentioned before, despite controlling for all these potential risk factors that could account for those disparities. Regarding our hypothesis that was based on evidence, we did not find differences, though, between non-Latino whites and non-Latino African Americans. We did find differences, as expected, between Caribbean Latinos and non-Latino whites, and we didn't find, as expected as well, between Mexican Latinos and non-Latino whites. And to our knowledge, we also found differences that were never reported before in the mild cognitive impairment literature, including Native Americans, those reporting African American race plus another minority race, and those of Central South American, those Latinos of South and Central American origin. This study has several strengths and limitations. Perhaps the most important strength was including a wide number of ethnoracial groups, but the most perhaps important limitation was recruiting from a non-probabilistic sample, which might have introduced, probably has introduced some selection bias and conflated, therefore, recruitment source with an ethnoracial group. Thank you very much. Here on your left, you have the reference of this publication. Thanks everyone for this opportunity.
That was great. Thank you so much. We're going to move on now. Just as we promised, it's a true data blitz. So our next speaker is Stephen Smagula, and he'll be speaking about sleep-wake correlates of depression symptoms and their neurobiological basis in dementia caregivers. Take it away.
Thank you very much for having me, and now for something just a little bit different. I'm Stephen Smagula. I'm pleased to share results from my NIMH-sponsored K Award. My research employs longitudinal designs and wrist actigraphy to identify sleep-wake behavioral targets for depression prevention in dementia caregivers. We also use MRI to evaluate the mechanistic context in which these associations occur, which could shed light on why these problems emerge and how sleep affects mood. Now, in my K01, we enrolled dementia caregivers who were stressed but did not have major depressive disorder in order to study subsyndromal symptoms and depression's risk architecture longitudinally. Within this sample, we found a squeaky clean group who had very minimal or no depression symptoms. You might think of these as the resilient caregivers. And this is what their sleep-wake pattern looked like. It's a healthy, square-like daily pattern of activity and resting. In contrast, the rest of the caregivers, about 40%, the rest of the caregivers, about 60%, had depression symptoms in the mild range. It was mild to clinically significant, about a PHQ of 5 to 10, CST of about 16, and that's a risk factor for MDD. What we observed was a large effect size difference where the caregivers with depression symptoms had less morning activity, in particular from 8 to 10 a.m. Now, there's a few important things to note here. First, this was not a circadian shift. There was no corresponding increase in evening activity. This was not due to insufficient sleep opportunity. In fact, the caregivers with depression symptoms were sleeping longer. And third, this predicted depression symptom persistence over time, suggesting it may be not just a consequence, a benign consequence, but rather it may contribute to causing depression symptoms. This is consistent with large-scale studies showing that people who identify as morning types are protected from major depression. And we actually did observe the same thing. You could enter the morning activity level that's objectively measured, or you could use a self-reported morningness scale. And those who were not morning types were doing worse in terms of depression symptoms. But what is morningness anyway? What does it mean to be a morning type? I want to point out that the common measures of morningness, like the composite scale for morningness, includes items about sleep-wake timing preferences, sleep-wake timing that people are actually doing, but also about perceived morning activation difficulty. And let's keep that in mind as we move forward, where we can now specify our goal of understanding why neurobiologically morning types appear protected from depression. We used 7T MRI and a resting state scan with high temporal resolution to ask this question of how does the resting state connectivity of key regions linked with depression differ between morning type and non-morning type caregivers? Our seeds were chosen based on a prior large-scale analysis by Drysdale and Liston, here. And note that these images are blurry because this is the actual average brain in my sample of caregivers, not a template or a single subject. Our main finding was that the non-morning type caregivers had higher resting state connectivity between amygdala and PCC, posterior cingulate cortex structures. Based on prior literature regarding these regions, we suspect this is reflecting allocation of attention to emotional distress. That is, more allocation or more depressive ruminations in the non-morning type caregivers. This resting state feature mediated or I should say statistically mediated the association between morningness and depression symptoms. And these associations were driven by items pertaining to difficulty getting going in the morning. Now, where does this leave us? Now, of course, depression can make it harder for people to get going in the morning. And based on our resting state finding, we think that this might have something to do with depressive ruminations or spending time focusing on one's distress. At the same time, it's also plausible that some caregivers would benefit from help getting going in the morning, and that this may exert downstream effects on depression pathophysiology. There's lots of reasons to think that helping caregivers get active in the morning, not all of them, but the ones who are having trouble getting going in the morning would be useful. Doing something in the morning, say knitting, can divert attention from focusing on distress. Boosting activity engagement in the morning could increase reward exposure, giving you something to do that could be rewarding or something to look forward to, like giving a loved one a new scarf. Also, morning light can have direct positive effects on mood. And of course, getting people going more in the morning is just what we do to help people improve their sleep. So if you don't believe me, then you can read these quotes from dementia caregivers that in my study, they were said without me provoking them. And I think they're consistent with this model, and I'm out of time. Thank you.
That was fabulous. Thank you so much. I'm already thinking about sleep and environment. We're going to go on to our final speaker. Megan Zuelsdorff is going to speak on social biological dimensions of ADRD risk, resilience and disparity. Please begin, Megan. Take yourself off mute.
Okay, I'm sorry about that. Can everyone hear me now? I hope so.
Very good. Very good.
Today I want to thank the organizers for having me and for everyone for tuning in. The study that I'm going to be evangelizing on today is focused on what I consider to be a proximal social determinant of health, and that is stress. So as we can pretty readily imagine, I think all of the very fundamental or distal upstream social determinants that we've talked about so far, whether they're individual, like education quality or poverty, or whether they are neighborhood level, like disadvantage, we can imagine that on a population level, they associate very strongly with an elevated exposure to all different kinds of stressors. And that's really important because stress gets under our skin to shape health in our body and our brain via multiple pathways, both direct and indirect. So for instance, stressors and adverse circumstances can trigger a physiological stress response that when that activation becomes chronic, it can tax the body's systems and can actually cause permanent dysregulation. Ultimately, though, I think it's really important to think about the health behaviors that our ADCs are so often focused on, these lifestyle factors, and imagine that the adversity and the challenge that we're facing at any given time can very strongly constrain the modifications that we're able to make for both the protective and the risk factors that we are exposed to in our lives. So thinking about, why am I stuck? Thinking about these kind of diverse pathways, I think it's not surprising that there's a fairly formidable body of literature demonstrating, as Dr. Barnes hinted at, that stress of all kinds, all different kinds of constructs, associates with ADRD brain changes like neurodegeneration, as well as cognitive decline and dementia risk. That said, I think there are still some pretty glaring gaps in that body of literature. So For instance, although we are starting to scratch the surface on this, I think the contribution of socio-environmental stressors to pretty well-established but still underexplained social disparities in cognitive aging and dementia risk, it's still unclear, and I'd argue understudied. At the same time, we know that there is significant underrepresentation of a lot of populations in our study design and in our cohort. And what this means is that there are a lot of voices and experiences that are just wholly missing from that body of literature. And what that means is that we don't necessarily have the community specific level data that would help us to tailor interventions or to bolster resources that are already working and helping people in communities. And finally, the truth is that stress is actually a little bit difficult to measure. The tools and the instrumentation that we have at our disposal, while there are certainly innovations happening, they may not be totally adequate, and that's particularly true for those same underincluded communities. So it's really those gaps that drive the study I want to talk about, the initiative that's going on. It's the Stress and Resilience in Dementia, or the STRID study in the UW-Madison. STRID is built on the infrastructure of the Wisconsin ADRC and the Wisconsin RAP study. The protocol that I can talk about is definitely tailored to the communities that we serve in Wisconsin. So STRID prioritizes inclusion of Wisconsin rural residents, our African American and our Native ADRC and RAP participants. But I guess what I would argue is that the basics of this approach could be useful and could be helpful to a number of ADCs and their community partners with some adaptation based on community feedback. So the basics of that protocol: STRID is designed to be minimally invasive and burdensome. Participants can, following consent, complete almost all the study procedures at home. They provide us with data on both universal and what I'll call community salient stressors and resources. They also provide saliva so that we can look at physiological stress and a validated measure called allostatic load. And I'd argue that actually diving down and looking at physiological indices of stress can be really helpful if we're trying to understand very distal social determinants of health, because of the way that physiological stress markers are able to account for exposures that are really important, but might be difficult for participants to report or for us to measure. Things like the toll on the body that chronic broken sleep can take, or undermanaged morbidity, or exposure to environmental contaminants like air pollution. All of these life course exposures that we know correlate with distal social determinants of health and adverse social conditions. So with these data, we are, through the STRIDE study, looking at addressing some of those gaps I mentioned in a very direct pathway. We're looking at the associations between life course adversity and ADRD biomarkers, as well as cognitive changes and how those relationships vary by race and rurality. We're looking at physiological stress as both a mediator, but also as a potentiator, a reducer of cognitive reserve. And finally, most importantly, we're also trying to look at population relevant resources and how they buffer those relationships. That said, that's the immediate goal, and certainly that's a variety of stress related mechanisms, but I'd argue that collecting these social data overall, the significance is not going to be in just establishing these socially rooted stress mechanisms. It's going to be in pairing these data with all of the ADC and linked study factors that we're so interested in. So I've placed the STRIDE data in green. It's about an hour's worth of data that people are collecting within all of the existing data that we have within actually the health disparities framework that's come up. And what I hope it illustrates is the way that filling in these contextual gaps, so having variables from across social contexts, can really help us do better in terms of addressing behavioral factors that we want to modify, as well as things that bring people into our studies: recruitment, retention, finding the barriers and the facilitators to do better work. I'm sorry if I've gone over. I'm excited to turn this over to the discussion now.
That was a great job. I really appreciate this. Wonderful speakers. Now I'm turning it over to our two keynotes who will conduct the discussion for us. So Amy and Lisa.
Okay, thank you very much, Dr. Sano. Perhaps what we can do is look through the question and answer, Dr. Barnes, and pick a few. There are more here than we'll likely have time for. There's already 17, but perhaps we can take turns. What do you think?
Okay, good. You go first.
Okay, wonderful. All right, we're going to go up. Let's see. There have been a number of questions to talk about specific measurement of valid constructs around social determinants of health. There's a number of questions that speak to this theme, and perhaps Dr. Barnes, Dr. Zuelsdorff, Dr. Perales, and Dr. Smagula, you can talk a little bit about how you think the balance between validity and participant burden could be best met by some of the tools that exist for the social determinants of health assessments.
So I'll start, and then I'd like to hear what the others have to say about this. You know, there are a number of validated measures. I mentioned the everyday discrimination scale that's been used in thousands of studies. And the Cohen perceived stress scale has also been validated. You know, some studies actually will not have validation because we are tapping into constructs that have not been examined before in diverse populations, right? So because of the under-inclusion of minorities, a lot of times we don't have those rich experiences represented in the literature. And so, you know, we can look at those constructs that have been done in predominantly white populations, but we don't always get the same answers. So I think some of us have to be involved in the work of creating new measures and going through the steps to validate these measures. You know, we can certainly start with what's out there. And I think if we're looking for something quick and dirty, that some of the things that I talked about in my presentation and you've seen in others will work. But I think we need to do a lot more to get at some of the really rich experiences that our older, diverse populations have, you know, things related to acculturation, things related to, you know, the lived experience of you know, living in food deserts, you know, things like that. But I'd like to hear what others have to say.
I wanted to make a point. There's ecological variables that we can get from the census or others that, for example, of neighborhood deprivation and that sort of variables that we can use without burdening participants.
Yeah, and if I might add, I completely agree with everything that you both have said and all of the wonderful information shared by Dr. Barnes. I think there are situations in which we may be limited either because of resource availability or because in the case of brain bank participants, they have died. And so asking them information obviously becomes very difficult and becomes secondhand through family members and things of that nature. So there may be different situations in which different approaches need to be used. And so having a comprehensive suite of tools that are validated and allow us to think about these issues from multiple different vantage points, I think is in the best interest of the entire field, for sure. Anything else? Anyone else want to answer that one? There is one follow-up, Dr. Barnes, if I could, if that's all right. And it was a follow-up on this idea of immigrant status and whether some of these measures change in their validity or are more or less valid for individuals who have lived outside of the US for a substantial portion of time.
You're asking me that?
Anyone.
Oh, okay. Well, I can speak to the everyday discrimination scale. That's actually been looked at across different populations and inside and outside of the US. So I think that I really like that scale a lot. I'm sort of biased. I've looked at it with many different outcomes. And, you know, it's incredibly predictive, even though in our older adults, the self-report levels are very low. It's surprising because you know that this cohort of people experience the, you know, the most egregious discrimination, but yet their reports are very low and it's still predictive. And I've seen, you know, studies across the US and outside the US showing this very similar results. The other ones I'm not so sure about, but maybe people who actually study immigrant populations can speak to that. Jaime, do you know?
I missed that question. Could you repeat that question, please?
The question was measuring these constructs of social determinants of health for populations that may not have originated within the US or had lived a substantial time outside the United States.
Well, one important thing is using validated tools. So tools that have been used for example, Spanish speakers in the United States is key for every single thing that you want to measure, actually. Regarding that scale, I also use acculturation scales. Sometimes they include discrimination towards immigration particularly. So that's another option.
Thank you. And I can speak from the geoanalytics standpoint that many countries actually already produce these types of measures like the ADI, and they're available publicly in places like the UK, Germany, many, many different places. So there are opportunities to do assessments using publicly available data from other countries as well. All right, I'm going to turn it over to Dr. Barnes.
Okay, thank you, Dr. Kind. There's actually a really great question for you, but I think that's something that all of us can weigh in on. This is a question from Dr. Manley. Your research on neighborhood factors is so important, and I appreciate your emphasis on feasibility during this talk, given issues of selection bias in AD brain bank data and use of cross-sectional data sources. I would like to ask about your thoughts about adjusting for race in this research. In other words, how do you properly adjust for race when comparing people living in disadvantaged neighborhoods to people in advantaged neighborhoods?
Yeah, I think that's an excellent question, and we can approach it in a number of different ways. I do a lot of work with Medicare data in which we're dealing with millions and millions of participants, and in those cases, our statistical tools are much more plentiful. When we're dealing with much smaller available samples, then we have to approach these things through very careful subgroup assessments, validating the approach and being very careful about how we interpret the findings. So certainly with the two papers that I presented today, they do need to be expanded into additional cohorts so that we have the sample size available to really tease apart some of the race and ethnicity effects. Interestingly, some of the brain bank data that we used did not have complete information on race, particularly for the individuals that were decedents in the pre-NAC era. So missing data becomes a challenge as well. And I think it just speaks to the fact that we can do this work from a feasibility standpoint, and there are still opportunities to move it forward in a number of different ways to tease apart the race and ethnicity impact. And the other factors along that mechanistic model that has been put forward by the NIA. There are many, many other factors that could be looked at. So it's an excellent question, and we're only at the beginning of a very long journey.
To follow up with that, Dr. Kind, I was really struck by your graph where you showed the most disadvantaged and the least disadvantaged, and how for people who were donating their brains really didn't have a lot of representation from the least disadvantaged groups. And it really suggests that we are not reaching those populations when it comes to our ADRD research and brain donation efforts. So, you know, I'd like to throw out to the group, like, what are some things that we can do to change that so that we have a better representation and we're not criticized for having this really select sample in the ADCs?
Yeah, absolutely. That's such a great point, Dr. Barnes. And I think there's so much more that can be done. Obviously, you have done such wonderful work in this area over many, many years, as have others who I'm sure are in the audience here, to respect that and to realize that there's yet more to be done. And could we certainly target on the basis of geography as well as on the basis of individual characteristics? Can we think about outreach efforts that are targeted to certain highly disadvantaged neighborhoods? And can we think about opportunities for expanding brain bank donation networks outside of the clusters around the ADRCs themselves? Many ADRCs do that, but I think there's opportunities for more. As part of that same paper, we had done a geoanalytic assessment of the catchment area within a 100-mile span of each ADRC across the country, and it was disproportionately populated by wealthy neighborhoods for the most part. There were certainly disadvantaged neighborhoods within those catchment areas, but there were more disadvantaged neighborhoods outside of the catchment areas. And so whether there's an opportunity to expand the network as well, but ultimately I think it will be a multi-pronged approach. And I'd be curious to hear others as well in thinking about research outreach and whether we can improve the population generalizability of the samples that we study.
Dr. Khan, I agree with you. We all face this issue. I'm here in Pittsburgh, and our samples do not represent the distribution of race and ethnicity. And the only way that I know how to solve this problem is through community partnerships and outreach. And on my latest grant application, I specifically asked for a recruiter, for someone who was going to actually put their feet on the ground and do the work. Because we can't just sit here and think everybody has equal opportunity to be in these studies, but because we put a flyer up or we put something on a website, we have to go out there. The churches around here seem to be the most helpful, but there's other community organizations as well.
I have another one. I think holding researchers accountable by the NIH will be important. So whenever we apply for a grant, we add this table of recruitment. Basically, if you don't reach this quota, something happens, or if you reach it, something happens, positive or negative. So some kind of contingency for accountability at the policy level, which is at the top of the social determinants of health, would apply here too.
Yeah, wonderful, wonderful. Well, it seems that we have time for one more question, and let's see.
Dr. Zuelsdorff.
Yeah, I think so. I haven't heard Dr. Zuelsdorff talk, so let's be sure to grab her. So Dr. Zuelsdorff, there was one question for you from an anonymous attendee that says, I wonder what approaches for capturing lifetime psychological stress you're thinking about employing, and whether you have any thoughts in that area.
I do. I really like the MIDAS Lifetime Stressful Events Questionnaire. It covers a lot of events. It covers 27, and it looks actually across the entirety of the life course. So you're capturing childhood stressful events where we see a lot of focus, and then you're really able to tie them in with potential mediation or exacerbation by later life stress. That said, I still think that, so I have looked a lot at lifetime stress, and I still think that a lot of when we see sort of differential vulnerability, we see stronger relationships between stress and health, say in a Black population or in a Native population. I think it's probably in part because we are still underestimating people's experiences. They're not there. So I think about this from, I live in Madison, and I'm asking, Wisconsin has some of the largest racial disparities in the country. And I'm asking participants about experiencing the death of a child or experiencing legal difficulties themselves, but I'm not asking them about the death of a grandchild, even though we know that infant mortality disparities are atrocious here. So I just think part of it is going to be doing qualitative work and also listening to our participants, what they're telling us when we ask about stress, and making sure that we are working toward improving the measures. But for now, I think the more items you ask about, the better. And there's a number of questionnaires. I like the MIDAS one.
This was an incredible presentation. This was an inaugural event, and every one of our speakers did us proud. I am so impressed with this. We had a great audience, incredible participation across all our panelists, and really highly developed presentations that everyone could grab. I want to thank you all. I know we're really right at our time, and I'm so impressed that we fit it all in. So I'd like to thank all of our participants who attended, as well as our panelists. And we'd love to hear feedback. If you are interested in telling us how well this worked, we will make an attempt to capture your questions and see if we can provide you with answers. And you can look to the NAC listserv. It'll help us share where you can find those answers. So with that, I'm about to end the program, but say it just couldn't have been better. Thank you all.
Thank you, Mary. Thanks, everyone.
Thank you.
Thank you.